I have a question for the audience before we move on to our next speaker. How many of you routinely report the MICs along with your categorical interpretation? Can you raise your hands? Oh, wow, that's great. And of those, okay, keep your hands up. Now, how many of you know, or how many of you think physicians know how to use the results that you're generating? So I think this is why, I agree with Dr. Schreckenberger, why we need our PharmD colleagues. And they are invaluable to the laboratory in helping us communicate interpretations for the tests that we perform in the clinical laboratory. So it's my pleasure to introduce our next speaker. Dr. James Lewis is the ID Clinical Pharmacy Coordinator at Oregon Health and Science University. And he's going to talk about antimicrobial stewardship, moving beyond rapid identification to high-speed susceptibility.
So what time did the session start this morning? 8 a.m.? You guys need another glass of wine, and you are to be commended for powering through. The other thing I will put out there is that when I give this talk to ID physicians, when they see this, usually the speed with which they head for the door is rather impressive. So it really bodes well that you guys are willing to power through. You're not all pharmacists in disguise, are you? I will do my best to keep you guys awake for the next little bit and hopefully also convince you that a lot of what Dr. Schreckenberger said couldn't be more true, and that from someone who does this day in, day out and makes drug dose selections in critically ill patients with organisms with varying MICs, it's very, very hard to function without that MIC information. And so while you've heard and seen a ton of the resistance marker, determinant, and resistance gene testing out there, which is hugely helpful, as Dr. Schreckenberger alluded to, there are caveats in places where you still absolutely positively need that MIC. All right, so what we're going to cover in the next 20 minutes is we're going to do a brief review of PK/PD. And I say brief in order to keep you all from starting to cry and weep openly. I just want to kind of refamiliarize you with that terminology a little bit because it's going to be so critical to what we talk about for the rest of this. And why this is important to you. Your ID groups, your clinical PharmDs are going to be really leaning on this science more and more as we move forward. That's the bad news for you. This stuff isn't going anywhere. Lou Rice, 7 to 10 years ago, stood up at ICAC and told the ID societies and the ASM group, look, we need to know this. We need to be able to speak this. And this is how dose selection is occurring. This is how we're monitoring patients day in and day out. It's a big deal. And I will show you why the resistance gene is not enough in a lot of these situations and wrap up with kind of a conclusion as to how the data that I've shared with you supports the need for a rapid MIC. So when you look at these agents that you've got in here, what I really want to focus on and where we're going to spend most of our time tonight is over here. Okay, we're going to spend most of our time on the time-dependent antibiotics because, guys, that is 80% of the antibiotics currently on the U.S. market. When you think about the penicillins, the cephalosporins, the carbapenems, and aztreonam, which are your beta-lactams, that is the vast majority of your inpatient armamentarium. And because of that, this time above MIC thing becomes extremely important. When it comes to Piptazo, when it comes to Cefepime, when it comes to Meropenem, I can take the truck, back it up, and dump it into the patient. And it will not kill that bug any better than if I just hold that concentration at 4 times the MIC. The concentration doesn't matter once you exceed 4 times the MIC. It's all about maintaining those drug serum concentrations above that MIC for as long as you can. And what you see here is that other drug classes do other things. We're not really going to spend a lot of time there tonight because you've already had a couple glasses of wine and you will go face down into your plate if I choose to continue down this path. So let me talk about a couple things here. The first issue that we've discussed is the importance of the MIC, but what I don't want you also to lose sight of is that there are really 2 variables that go into any PK/PD equation, okay? The first is the serum pharmacokinetics of the drug, the PK. All right, so the PK is absolutely massive, and the PD is really driven by the MIC of the organism. So you have a need for both your micro and your pharmacology. And in case you haven't noticed, hospital administration hates both micro and pharmacy equally. We are both cost centers. We should be best friends. We should all be hugging all the time, okay? And so, but the PK here really is absolutely big. And one of the reasons that the MIC is so big is because the more we look at the pharmacokinetics, especially of our frontline beta-lactams in critically ill patients, the more we realize we don't know what we're doing. And that really is a problem, okay? Because now you've got two variables that are driving patient outcome, pharmacokinetics and an MIC, and you don't know either. Anybody feeling good about this? Okay, so those are really the two things that are driving this. And I bring this up because this study makes a couple very important points. It was a prospective, multinational, point prevalence study on a given day of multiple ICUs across multiple countries. And what they did was look at serum concentrations versus outcomes. So again, you're looking at, as you were doing better with your serum concentrations, how were the patients doing? And they looked primarily at 8 beta-lactams that were commonly seen in a lot of our ICUs out there, with a median age patient of around 61 and an Apache 2 of 18, which is, again, very consistent with what we see in a lot of our ICUs. Now, where we really start to run into trouble here is on this slide, okay? And where I want you to focus is up here. This table up here, look at this. Cefepime is at 6 grams. Paul alluded to the fact that there are multiple dosing regimens in the package insert for Cefepime, which is a huge problem. But I will tell you that none of them go higher than 6 grams. So this is max dose right here. When you start pushing above 6 grams of Cefepime a day, the patient starts thinking the tree outside their window is holding their grandchildren, okay? So we need to be a little bit careful with Cefepime, but this is max dose. The other thing that I want to point out here is that this is a very good dose of doripenem. Piptazo at 4.5 grams roughly every 8, which is kind of our standard European, Australian dosing. And then Meropenem sitting here at a gram Q8, which is extremely common in most of our hospitals in the US. So there's really nothing here that screams underdosing. If anything, we're going a little bit high. Now, remember we're talking about time above MIC here. The most conservative thing that we do to set a break point is 50% time above MIC. So this is minimum. This is bare bones. If you start dipping below that, the animals start dying in the lab, okay? So this is a bare bones marker. Look at this. This is how often these patients were 50% time above MIC, 3/4 of the time. You did pretty well with doripenem. When you got into Piptazo, 1 out of 5. And I guarantee you that if you walk into most ICUs in US hospitals, Piptazo is everywhere, okay? So Piptazo's everywhere, Cefapime's everywhere. Meropenem did pretty well, sitting over here. But now, if you say, okay, that's the bare bones minimum, I want to do better than that. I want to hold 4 times the MIC, which is where we max out our beta-lactam killing. Look how rapidly things start to deteriorate as you come down. You're at 50% for Cefepime, under 50% for Piptazo. Guys, this is a problem. So I think one of the things we're going to be talking about in the not too distant future is not just your need to be able to generate rapid, accurate MICs, but also therapeutic drug monitoring in critically ill patients. This is going to get more complicated on us, not less. And one of the things that was very, very interesting from this study, what they found was that the higher the drug concentration went in ratio to the MIC, the better the patients did. So again, you see yet again here that the MIC is playing a major role as a predictor. And also, in my situation, if I've got a toxic drug, I need to know if I need to push it. Okay, I need to know if I need to take that concentration up because I have a high MIC bug, or can I get away with a little bit less and still make some of these targets because the MIC is lower. So again, pharmacokinetics and the MIC drive all of these equations. They drive so much of our breakpoint setting now. This stuff is absolutely essential. So let's take this to the bedside a little bit. You got a 27-year-old male with AML. Okay, he now has, and it's been taking, look at this, it's been taking a gram Q6 of vancomycin to hold his vancomycin troughs above 10. This guy has 27-year-old kidneys, and he is in a hypermetabolic state. He's blowing through drug like there's no tomorrow. Anybody feel good about trying to put Piptazo, Cefepime, or Meropenem into this guy? He's clearing drug like there's no tomorrow. And now you've got Pseudomonas aeruginosa running around in his blood. So you've now got a guy who's clearing drug in a hurry, and you've got an MIC situation. When you think about Pseudomonas, do you think high MIC or low? Right? The wine is really good, isn't it? Yeah. You're like, can I get another glass of that Chardonnay? He said Pseudomonas and MIC, and I've been thinking since 8 a.m. But we all know that Pseudomonas runs high. Okay, so this is kind of a worst case scenario. You've got a high MIC pathogen in a guy who's clearing drug in a big hurry. Your molecular testing du jour, okay, your BioVera expert, or whatever you choose to call it today, says there's no resistance genes present. In Pseudomonas, that tells you nothing, okay? Because as Paul alluded to, it can do porins. It can do efflux. It can do some OXO 1,948,000 you've never heard of, okay? And that's the problem with Pseudomonas. It is the scene in Matrix where the guns fly by, and the Pseudomonas can pick any gun it wants anytime. So these genes, these 8 to 10 genes we're looking for, ain't buying us diddly squat when it comes to dealing with Pseudomonas here. So the clinician now has a bug. They have no resistance markers, or so they think, but they have no MIC, and this 27-year-old doesn't have a white cell in his body. This is not going to end well because the antibiotic now has to do all of the heavy lifting. So what do we know about Piptazo dosing in Pseudomonas? This is where the PK/PD stuff really starts to kick in, okay? And like Paul alluded to, there are different ways to give Piptazo. How many of you know in your institution how Piptazo is standardly given? So yeah, you guys, this is, again, a great opportunity to talk to your pharmacy, to talk to your ID group, to find out how they're administering stuff. Are they doing it extended infusions? Because look what happens here. Like Paul alluded to, the breakpoint used to be 64, and we won't go into that train wreck. But now that they've dropped it to 16, you can see you're doing pretty good here at an MIC of 4, kind of irrespective of how you give this, okay? But as the MIC starts to creep out into the 8 or 16 range, up near the top of the susceptibility breakpoint, where we know a lot of our Pseudomonas isolates live, now all of a sudden you have to start doing extended infusions in order to be able to hold that. And when you have a 27-year-old guy, this study was done in 61-year-olds, you really had better push the dose. And you had better optimize the PK/PD by giving extended infusions. And let me tell you guys, I want an MIC on this bug yesterday in a patient like this, because this guy will be dead on you in a heartbeat. He has no white cells. He's got one of the worst bugs on the planet running around in his bloodstream. And we're really guessing with regards to how we're dosing our antibiotics here. So the one thing that always comes up is that people are like, that's great math, but all your PK/PD is basically a random number generator and a whole bunch of, advanced math, and that's all well and good, but prove it to me in a patient. There you go. Okay? This was a nice study that was done out of Albany now, going on about 8 years ago. Other studies subsequently have largely confirmed these results, and what they looked at were infections due to Piptazo susceptible Pseudomonas isolates. All right? And what they did was 194 patients, 102 of whom got extended infusion. The other people got the 30-minute infusion. What they saw was that there were really no differences in baseline patient characteristics, but there were some subtle stuff there. And remember, this is a retrospective study that comes along with some of the limitations associated with those. But what they saw was that when they looked specifically at the patients who had an Apache 2 score greater than 17, i.e. the sickest of the sick, okay, where the drug really did need to do some heavy lifting, that the 14-day mortality was considerably less with a p-value of less than 0.05. Not bad, okay? So you basically were able to improve survival with Piptazo by extending those infusions because the bug runs a higher MIC. You need to play games with your Piptazo a little bit to keep it up above MIC because your normal half-life in an adult is about an hour. But again, you can't do PK/PD without an MIC. Have you ever tried to plug CTX into an equation? Have you ever tried to plug Vim into an equation, right? Doing math with a resistance gene, very problematic, okay? So it really, the MIC drives so much of this. What about Cefepime? Okay, we know that Cefepime is a workhorse drug for us in a lot of our centers as well. Again, single center, retrospective, Pseudomonas patients, worst of the worst. MICs are gonna run up around 8 for most of these bugs, sometimes pushing out towards 16. What they looked at was 30-minute infusions of Cefepime, 2 grams, as compared to 4-hour infusions of 2 grams of Cefepime. And again, what they saw was that mortality improved, length of stay in the hospital really didn't change, but when you come down here and look at duration of mechanical ventilation, with a lot of these again being pneumonia patients, you saw a statistically significant difference yet again. Okay, so you've now got mortality benefit, you've got time on vent benefit, and all because you're making sure that the PK works well with the MIC of the organism that you're treating. So what about this guy? What about a 42-year-old liver transplant who's been sitting up there for 39 days? Everything that could go wrong with her liver transplant did. Multiple complications, multiple rounds of broad-spectrum antibiotics. The patient's now hypotensive yet again, okay? Blood cultures and molecular testing, again, the BioVera expert, okay, tell you that you now have a Klebsiella pneumoniae that is KPC positive. Your ID pharmacist, as this is actually a real case, and all good things in hospitals happen after 4 p.m. on a Friday, this happened after 4 p.m. on a Friday. Okay, so we have all of these answers, and I think I'm going out the door for a lovely date night. I forget what movie I was going to see with my wife, but this promptly got blown up by this fun-filled Klebsiella. So the transplant team is calling me going, what do we do with this dude? And I have no MIC. So basically it is take everything we've got and give a lot of it. Now the problem with this is that when you get into KPC, everything you've got includes Barfacil as well as Tide laundry detergent. Is anyone terribly excited about giving yourself intravenous Tide laundry detergent? I mean, colistin. Okay, how about a drug that I have seen when you walk into the room the next morning after starting a patient, they have blown all of the blood vessels in their eyes and have blood red eyes from vomiting all night. That's what tigecycline does for folks. We lovingly refer to it as Barfacil. We also call it Tigafran because it needs to be combined with the antiemetic Zofran. Okay, so neither drug works well. Oh, and did I mention that the pharmacokinetics of both of those agents are absolutely atrocious? Okay, so you're taking poorly tolerated drugs that are toxic with poor pharmacokinetics, which means I have to crank on the dose. See why I want an MIC? Okay, see why this is important? And this makes it even more important. This is the Tumbarello paper from Clinical Infectious Diseases in 2012. What I want you to focus on is the left side of the table, which is the Meropenem MIC. These are KPC positive organisms from bloodstream infections that were treated with a combination of Meropenem plus tigecycline plus colistin, or they got some variation in there, okay? So not everybody got all 3. There were some that got 1, some that got 2, some that got 3. But what I want you to focus on is the left side of the slide here, the Meropenem MIC. These are the total number of patients that were involved, and look at the number of non-survivors. Remember that KPC infections typically have an accrued mortality rate of roughly 40%, okay, 40. Greater than or less than 40 as you go down is the question you need to be asking yourself. Notice that and remember your CLSI breakpoint is now 1 for these, okay? So you can still deal with these up into this range and maybe even some of these, okay? Now, what happened in every one of these patients is actually very interesting. We've already talked about how bad colistin and tigecycline are, but what happened is that all of these patients got Meropenem, 2 grams every 8 hours, 3-hour infusion adjusted for renal function. Now, I will tell you right now, it's Friday afternoon. I know I've got a KPC positive organism. I've got to dose Miro or Dory. I don't freaking care what their renal function is. I'm cranking the dose and we're going great guns. So if these are anything like the clinicians I know, until their creatinine clearances got less than 10, they didn't adjust that Meropenem at all. Okay, so you're getting big Meropenem exposures. And again, go back and look. Remember, this is now your resistance breakpoint, and as you're sliding down, you're still picking some stuff up. I'm arguing that the reason you're doing that is right there. You're giving big dose Meropenem to these people. Look at the folks in this arm. 90% survival as compared to usual 40% mortality. So again, the Meropenem MIC here becomes absolutely critical to you, not just the presence or the absence of the resistance gene. All right, so let's wrap up, because when I was putting this together, a friend said to me, you're giving absolutely no love to the gram-positives. And anytime you do not show Staph aureus respect, it eats you or someone you know, okay? There is a reason that more than 50% of the calls to the ID consult pager involve this bug right here. We lovingly refer to it as the king and the queen, or Mr. Saw and Miss Saw. That is the level of respect that they have earned with the destruction that they cause. Now, I'm therefore giving them their stage time, all right? And in case you haven't heard, you've been living in a cave somewhere, there is a bit of controversy about vancomycin MICs versus outcomes in MRSA infections, just a wee bit, maybe a little bit. And the problem with most of the data sets on this topic is that they've been single-center, they've been retrospective, there have been a lot of challenges with who went into what group and whatnot, and because daptomycin and various other brand name agents cost roughly, daptomycin is now anywhere from $360 to $720 a day. That is pharmacy acquisition. Want to guess what the patients are charged? So that's per day for Dapto. Linazolid just went generic. We had a block party in the pharmacy when that happened. We invited Micro. The beer was awesome. It's Portland, okay? And but the other new agents that are out there, guys, you're talking Vanc. All right, Vanc is $6 a gram. Okay, $6 a gram versus $720 a day. Guess what? My pharmacy director throws heavy objects at me every time I start somebody on Dapto. So you can see that there are financial reasons, patient care reasons. There are a lot of reasons to be very concerned about what's going on with Staph aureus MICs versus outcome. Now, this, to me, is still the best data set out there on this topic. It was a prospective data set done over an almost 2-year period out of Australia, New Zealand, with about 532 patients, so a very large data set as well. They looked at the impact of vancomycin MIC on 30-day mortalities, and we kind of have talked about what some of the previous studies have shown, that as the vanc MIC drifts up into that 1.5-2 range, that outcomes appear to be worse. Now, here's where I think these authors were flat out brilliant. And when you look at this, what you'd say immediately is, well, okay, Jim, duh, the higher MICs did worse. Okay, yeah, we already knew this. This is a rehash. Take a sip of wine and think about this one for a minute, okay? Notice the drug sitting at the bottom of the slide here. That is flucloxacillin, which is equivalent to the nafcillin oxacillin that you're familiar with in the United States. So these are anti-staphylococcal penicillins. These are MSSA infections. MSSA infections managed with what are widely considered by ID folks to be the Ferraris of the anti-staphylococcal world, which are the anti-staphylococcal penicillins, okay? And the vanc MIC mattered. Huh? I had to have another beer after looking at this one. I had to come back and reread this paper like 3 or 4 times. But what this again says, and I don't know how to explain this. I've talked to John Turnage ad nauseum about this paper. He's like, the more I look at this data, the more confused I become. And what I think this says is that not so much we necessarily need to switch immediately, because even patients managed with the best drugs we've got didn't do as well when the vancomycin MIC was higher. Something else is going on. So from a financial standpoint, we take a beating when we switch, see previous daptomycin expense comments, but something is clearly going on. And what this says to me at this point is that we probably need to be much more aggressive with source control, debridement, pulling lines, and the like when we see these MICs. Now the problem is that the BioVera expert tells you MRSA or MISA, which is awesome. It's absolutely awesome. And it's way better than waiting 3 days to know MRSA. But even when it's MSSA, something's going on with the vancomycin. Is it the bug? Is it the people who get these MICs? I have no idea, but something is going on. So to wrap this up, the resistance genes are absolutely awesome. And as an antibiotic stewardship person, I flat out love having that information available to me. But don't lose sight of all the stuff Paul was talking about. Those machines are only calling the genes we know about, the genes they were built for. The other thing too is that it doesn't give me an MIC. And hopefully if I've convinced you of one thing tonight, it's that the MIC really does matter when we're dosing antibiotics in critically ill patients. It is a very big deal. And the faster I have that MIC, the better, especially in the types of patients that we were discussing earlier. The more resistant the organism, the more the MIC is important. Take a look at that Tumberello data. I think it speaks volumes, or even KPC-producing organisms. That MIC for Meropenem appears to really be doing something with outcome, and I think it's because that's the driver of the PKPD, and the lower MICs are getting better PKPD. So that, I think, is where I will stop.